Welcome to this episode of Orthodontics in Summary. Now today's podcast contains a series of 3 lectures that are going to be covered from the American Association of Orthodontics meeting this year from May 2020. The topic we're covering in this series of lectures is going to be of early treatment. Specifically, we're going to be looking at dental trauma relating to ankylosis. We're going to be looking at airway diagnosis and orthodontic treatment, that controversial topic, and also the optimal timings for Class 2 correction. Looking at really what is the best patient to receive Phase 1 and who should we really be avoiding it for later on treatment. Just a reminder, the podcast is the opinion piece of myself and may not be 100% representative of the lecture, although we try our best to ensure that it is. It is the independent work of myself and the Orthodontics in Summary team. So starting off with the first lecture, this was by Eustaquio Araujo, and he spoke about dental trauma. Now his introduction stated that around about a quarter of all 12-year-olds have experienced some form of trauma, and that's a global statistic. Boys twice as much as girls, and actually the incident takes place between the ages of 8 and 10. And really what Eustaquio's lecture was based around is his treatment protocol and how to manage ankylosis and his innovative ways of doing it. So what does he do? Well, when a patient comes in and they've had a traumatic event or an ankylosis, he will reposition the tooth with a firm grip, and that's the terminology he uses for his residents. He utilizes a 16 by 22 nickel titanium wire. And I think that's great to move on from the stainless steel splints to utilizing nickel titanium with its shape memory properties. He provides a bite prop for the patient, eliminating the occlusal interferences and allow the tooth to then take its position without any further interference, and a soft diet for the patients. Now, when it comes to reimplantation of avulsed teeth, typically we tend to be on the losing side, and that's because it has to be reimplanted within 1 hour to have 75% chance of revascularization, the tooth to be taken up. Anything after an hour and up to 24 hours, which is where Eustaquio mainly sees his patients, it's only 25% chance of success taking place. So what to do? Well, if a tooth ankyloses during orthodontic treatment? Well, Eustaquio showed 2 examples and how he managed it. The first involved decoronation of the tooth. The tooth would become ankylosed and subsequently had a root fracture. So he removed the crown of the tooth. I thought it was really interesting what followed. The rest of the pulpal tissues in the root were then removed, but rather than obturating it with a root filling material and allowing the apex to close, he filled it with blood. And this was to induce a physiological replacement resorption. And he stated this is the real advantage of this process. Yes, the root is going to be lost, but it's infilled with bone and maintains it to a time it can then be restored. Things are sutured back on top, and then the replacement resorption takes place. And the patient has a prosthetic tooth in the meantime as part of their appliances or retainer. Now, the second one related to an ankylosed upper incisor, but this time it was an older patient. What they did this time was carry out a regional corticotomy. What does that mean? Well, essentially it's the tooth is held within its current place of bone, but the bone itself is cut, both on the buccal and the palatal side. It's osteotomized, and that whole block of bone containing the tooth is now mobile. A bracket is placed onto the tooth and it is fixated against the wire. And that in turn allows the bone to be held in a rigid place and allows healing to then occur. He spoke about something that's changed his practice. It relates to Viela's paper from 2019. Now, it was a finite element study, essentially a mathematical model of what takes place when it comes to trauma. But what it showed is that actually blunting of the adjacent teeth is likely to take place. And his conclusion was to now look at the neighbours, as he termed it. I thought it was a great lecture which really looked into ankylosis and how to manage it when it does then take place through a variety of methods. The next lecture looked at airway-centered orthodontic diagnosis and treatment for pediatric patients. And this was a lecture by Hong Hee. She spoke about the common causes of airway obstruction, and it relates really for younger patients to adenoids and their tonsillar hypertrophy. And the effects of this, essentially the patient moves from what was defined as normal breathing, nasal breathing, to a mouth breather, and the effects that this has. So typically for the nasal breather, the tongue rests on the palate, but for the mouth breather, it rests at the floor of the mouth. Now this results in a change in pressure that takes place, with the nasal breather having the cheek pressure balanced with the tongue and a U-shaped arch form, whereas the mouth breather has something different. The cheek pressure is unopposed, there's a narrowing of the upper arch, creating a V-shaped arch form. Now, the lecture was broken down looking at two components: tonsillar hypertrophy and looking at adenoid hypertrophy. So looking at tonsillar hypertrophy first, it relates to the oropharyngeal area, and that obstruction results in changes to the tongue position by bringing it forwards by the patient, but also the mandible relocates forwards as well. And this was Iwasaki's paper from 2017. Now, what Hong-Hee did is a large review of their patients, looking at nearly 2,000 patients, and found that actually, when it came to looking at tonsillar hypertrophy, it was more common in class 3 patients, both in children and in adults. The caveat here, as I interpret her information, is that actually it came from a cephalometric study that she carried out, maybe not the best measure of tonsillar size. The second was looking at adenoid hypertrophy, and this is further up, and it's an upper airway obstruction. Now, it has occlusal effects, the main being it narrows the transverse component of the maxilla. This is a knock-on effect. The mandible tends to rotate clockwise and is retruded, and this is also unfavorable when it comes to orthodontic management when it comes to the vertical component. Hong-Hee then spoke about the 2012 Pediatric American Academy guidelines when it comes to adenoid tonsillectomy. Essentially, when it comes to an airway obstruction relating to hypertrophy, it should be the first line of treatment for patients to have the adenoids removed. Now, what effects does removing the adenoid and tonsillar tissue have? Well, looking at the contemporary studies now, we find that when it comes to the AP changes, it's very little. But interestingly, the vertical changes seem to be significant. There appears to be a counterclockwise rotation of around 4 degrees. That was Sun's paper, Systematic Review from 2018. When it comes to the transverse component after the tonsillectomy has taken place, we find there's an increase in the intercanine distance without any orthodontic intervention. That was Vera's paper from 2012. It's also important to note that the studies that were looked at, also by Casalexa from 2014, showed only around a 1mm change that took place in between pre and post treatment. What happens if the hypertrophy isn't corrected? And for me, this was perhaps the most controversial component of the lecture. What Hong-Hee stated was that there's a change to the appearance and the cognitive function of the patient. She mentioned how, from an appearance perspective, the weight and height of the patient is reduced pre-surgery, and after surgery, the patient's height and weight increases. This was Bonnock's Systematic Review from 2009. When it came to cognitive impairment, there was a systematic review by Sung in 2016, and it showed that patients before they had the adenoid tonsillectomy and afterwards, there was an improvement in around 7 points when it came to their developmental assessment, but also when it came to their IQ, there's an improvement of almost 4 points. Now, I have concerns over the last 2 bits. Reading into those systematic reviews, there was a large variation of what transpired. Looking at patients pre and post having their surgery, well, they are growing patients. We'd expect the height and the weight to increase. When it came to the IQ, actually there's quite a range of what took place. Even the controls had some improvements in their IQ, but most crucially, I think the age ranges were quite broad, and that can change the statistics that come out. And I do think that it's an interesting component to explore, but actually the reviews that were given in this, the papers that were provided in this particular lecture, didn't really answer the questions comprehensively, and I think there's still a large degree of uncertainty whether or not having an adenoid tonsillectomy is needed to have better height, weight, and IQ. And the final lecture looks at the predictors of success of early mixed dentition treatment for the Class 2 patient. This was by Heesoo. Now, it was related to the study that she had carried out in her institution, looking at, well, what happens when it comes to Class 2 correction? Now, she did acknowledge there's been a large amount of literature around this topic, but when it came to looking at the large systematic reviews, really within the mean changes, it masked the individual responses. And that's really what O wanted to explore. What are the individual characteristics of a good responder versus a poor responder when it came to phase 1 treatment? Now, the study was published by O in 2017 and essentially looked at phase 1 treatment for patients aged between 7 and 9 who underwent Class 2 correction. This was using headgear, RME if it was indicated, and a 2x4 appliance coupled with a lingual arch as well when it came to managing the mandible. Now, what was defined here when it came to a success and a failure of the study was looking at the duration of treatment. Actually, occlusally and skeletally, the changes were the same. So, it was defined as 33 months, or looking at 2.5 years, as being the cutoff point for what was deemed to be successful or unsuccessful treatment. Now, she looked at 54 patients that underwent this treatment, and they found that actually about a third of them only had to undergo phase 1, didn't require phase 2. When it came to looking at the total number of patients that were treated, actually 67% of them were treated within 18 months or less. They had phase 1 and and if needed then phase 2 as well. But what she really wanted to explore was the 20% who went on for 4 to 5 years of total treatment. Now I credit O with this straight away because they're looking at what went wrong and trying to understand those patients who were unsuccessful. And it boiled down to 2 categories of patients. Patients who needed expansion in the intercanine width, and I presume this is because they then needed to have RME or further expansion appliances, but also patients who were hyperdivergent, and that was defined at patients at 36 degrees when it came to their SN to MPA. Now, what was the greatest predictor? Well, actually, if you had these 2 combined together, hyperdivergence of 36 degrees or more, as well as intercanine width which needed expansion, actually the chance of succeeding were relatively small. Failure was present in 72% of these cases. So what was O's recommendation? Well, she's mentioned the hyperdivergent class 2 correction should take place using MARPE, some form of mini screw assisted expansion, and allowing some intrusion to take place posteriorly as well to plan for the future negative growth that will occur. My thoughts on this lecture, that it was great to explore the unsuccessful phase 1 correction and as to which patients that is not a good idea for. So now really looking out for the hyperdivergent patients, the patients with the narrow intercanine widths. However, I felt this study lacked some of the information we have from our other data and other evidences. For example, looking at the time between retention of phase 1 and phase 2. What was described in the study was the active treatment times. But also looking at this patient-related factors. What was their compliance during that period? But also looking at what factors related to the patients, their satisfaction in having phase 1 and phase 2 treatments. That's it for the summary of looking at the early treatments lectures from the AAO. A quick update for me, well, happy Father's Day to the fellow fathers out there. I really enjoyed the last couple of weeks going to the Ortho Simply event in Porto, which was a fantastic experience to have had, but also having enjoyed some of the online lectures that have taken place. The International Orthodontic Foundation, which Ravi Nanda is also involved with, hosted a free conference online. Actually, it's still available to the 30th of June, and I do recommend having a look at their contemporary lectures looking at aligners and 3D printing. What am I looking forward to? Well, I'm looking forward to the Benefit course, which is going to be online. This is by Benedict Wilms and Bjorn Ludwig, looking at the real use of the TAD system that they utilize, specifically when it comes to MARPE and looking at class 2 distalizers as well. That's it from me, and as always, please do subscribe and look forward to the next episode.